Now I call upon the Lord of the Rings, Dr. SUVEN, to present his talk.
Good morning, everybody, and thanks Sudeep and Savi to have Dr. Sai to have given me this opportunity. I love the name Lord of the Rings. Hey, you need a mouse over here, please. Can I have a mouse? Is there an external mouse over here? Because this is moving. No, no, it's okay. That's all right. But it's I can see the presentation over here, SUVEN BHATTACHARJEE, but what's happening? No, no. The control, the mouse is going. और हाँ यस गिव मी अ माउस ये चल रहा है अपने हिसाब से चल रहा है कंट्रोल करते हैं ना आप यहाँ से कंट्रोल कर सकते हो हाँ मैं कंट्रोल कर सकता हूँ लेकिन आपके यहाँ ये माउस जो है फ्लोटिंग माउस हो गया है वी आर यूज्ड टू दिस. Okay, good morning, everybody. Once again, so I'm be speaking on intraoperative meiosis and iris prolapse. So this mouse is freaking out. So I do have a financial interest in the BHATTACHARJEE People Expander, and thank you for being here. So intraoperative meiosis and iris prolapse, the spectrum is basically very simple. Three components: iris billowing, meiosis, and iris prolapse. Mild, moderate, and severe is graded on basis of that. So let's take a look at this video which I presented long back at ACR's and Arup's IC, and this was so. This is just to show you the three stages. That's a little bit of floppiness of the iris. It's billowing of the uh, iris and that fluttering of the pupil margin, which is so typical. In fact, some of these videos are from even before IFIS was recognized as an entity. So that is so typical of IFIS. You inject viscoelastic or reform the chamber and that pupil dilates fully, and then you just go ahead, no fault of yours, nothing wrong with your fluidics, and that pupil comes down suddenly on you. So that is very typical of IFIS, and you really can't control it. After some time, the iris starts prolapsing, and then it becomes messy. Yes, with time we have learned that if you reduce the flow rate significantly, you can control these movements, the movements of the fluttering of the iris, the prolapsing of the iris. We can do that, but in some cases it really gets nasty, and you really can't control all of it. So this is just to show that yes, the iris did prolapse, and maybe some steps we were not very good at it also. So that was the reason, and you see that. So you still see that the dancing pupil margin, and that is so typical of IFIS. Now, this is something where I like to show always that no device is actually infallible. Here we are using iris hooks to dilate the pupil, but unfortunately, I mean, I couldn't even finish my capsular exercise, and that pupil iris was all frayed, looking like a fishing net almost. And I'm having difficulty even putting my phaco probe inside. So it's always important to understand that once you've touched the iris, it's going to come to the phaco probe like a magnet, and we need to protect that iris every time we go into the anterior chamber. See that patulous iris over there, as I inject it, it kind of moves like a sail. So we need to be very mindful of whatever instruments we are putting into the antechamber, because that iris is perhaps it is going to get traumatized every time we go inside. Yes, what people devices do, iris hooks or expanders do, is provide us a constant pupil size so that we can do that phacoemulsification safely. See, again, I have to protect that iris, because if it just gets caught somehow in that nozzle of the injector, I'm going to land up with iridodialysis. So that's it. So we did manage to finish this case, and you see, and that is one way of repositing the iris, is basically to not go from the incision at which it is prolapsing, but instead use a side port to drag it back in. And in fact, you can use a little bit of wound hydration. Here, it does actually act a little counterproductively because the iris prolapses again. But once it becomes tight again and you pull it back, you reposit that iris, it will this time it won't come back because the wound is hydrated and there is no room for it to again prolapse. So that was pretty okay at the end of the day. Now this is a case where the pupil came down so typically halfway through the surgery, hard cataract. At this point, I had to take a call that no, I would not be able to do a safe phacoemulsification. So we needed a device. So to the to get back to that comfort zone. So inject a little bit of viscoelastic on that anterior capsular rim, Create space for the pupil device, whatever device you choose to use. Here I'm using a BHATCH pupil expander. A BHATCH pupil expander offers you a lot of advantage in terms of a device compared to others. Here, as you tuck that flange under that pupil margin and you draw it towards the limbus or periphery, you have instant confirmation that the pupil margin has not been engaged. And even if you've engaged, you can see it and you can withdraw a little bit and again retuck that, so that you are absolutely with the device like a mulligan ring or otherwise, where the gap is on the sides. With the top view, you really can't see that gap and you're never sure what you're engaging, the capsule margin or the pupillary margin. Once you're back to your comfort zone, you're back to your regular surgery. This is a video by Deepak Magur, and this is where again I want to show is the gaps in the scrolls in a device like a Mulligan ring are on the sides, and you really can't be sure. And that control with that injector is not good enough for you to be absolutely sure whether you're injecting, whether you're engaging the capsular rhexis margin or the pupil margin. Like I said, tuck that flange and take it a little to the periphery, and you have instant confirmation that you have not engaged the capsular rhexis margin. That is all you need when you have intraop meiosis after a capsular rhexis. So, if we had any thoughts that certain people's size is good for us and we will not have IFIS, well, this paper proved us completely wrong. For a people 7 millimeters or smaller, the risk of IFIS existed regardless of alpha blocker treatment. Now, some of us believe that in India we didn't have much of a problem. Well, unfortunately it's higher in India, and hypertension was found to be a significant risk factor. And over the years, we've come to know there are a huge list of risk factors. So that is the list of drugs which can cause IFIS and systemic conditions. Practically every patient walking into your operation theater is at risk. So these are the complications. Have I run out of time? Yeah. So all this can be avoided or minimized by the use of a good strategy. This is a slide which I would like to pay. I like you to pay special attention to. Floppy iris, meiosis, and iris prolapse. Iris hooks or pupil expanders will provide us a constant pupil size, which offers us good visibility for safe phacoemulsification. Iris prolapse, you really have no control. No device helps. It depends on the severity of the IFIS and the pathological damage to the stroma. So if you got away on a particular given day, it was your good luck. It was low grade IFIS. The device really had no role. So don't kind of have a blind faith that okay, iris hooks works better or certain pupil expander works better. That is not the case. Fortunately, surgeons all over the world are reducing the threshold because of unpredictability of IFIS, the more use of premium lenses, and the litigious society that we live in. So my choice of pupil expander intraop meiosis would be either iris hooks or a BHATCH pupil expander because it offers a surety that I'm not going to engage the capsular margin. Let's skip this. Okay, the advantage of BHATCH is that you can go in through very small incision. This is what I presented at ACRS recently. 1.2 millimeters is the incision that you require to go get in. That's the smallest incision that you can get to. Yes, you need to hold those flanges a little differently. Holding it to the middle will not really help because you're across that incision, or hold the flange at the end, and it does go in through a 1.2 millimeter. I don't think there is a device in the horizon which can go in through such a small incision. So we are probably future ready as far as phaco is concerned. And to remove it, you can take it out through a 0.9 millimeter side port incision. Again, no other people device could do that. You can just hold that flange, disengage it, and that could be very, very helpful in IFIS when you have the iris prolapsing through all ports, and if you have a shallow anterior chamber to add to that. So the lessons that we learned is the host of systemic conditions can cause IFIS. It can occur in patients with any size of pupil. And the best thing is women also are on tamsulosin, often for UTI. It's very commonly prescribed. We do not eliminate iris prolapse with devices. We just reduce the fluttering maybe to some extent, but it does provide us visibility for a safe phacoemulsification. So every eye is an IFIS candidate, and let's reduce the threshold for using a device. Thank you very much. I would encourage you to look up this particular article that I wrote on eoftha.com. Thank you.
Congratulations, Dr. SUVEN. As usual, amaze us with your rings.
Thank you very much.